Hi, welcome to your lesson on nervous system diseases. This is a rather short chapter, so it shouldn't take very long for us to cover this. All right. As way of introduction, our nervous system disorders usually result from impaired development, which of course obviously would happen in utero. So maybe lack of nutrients or chemical exposure from the mom. It can be birth trauma. It can be degenerative processes, deposition of abnormal proteins, ruptured arteries, and routine immunizations. So all of those can cause nervous system disorders, and we're going to get into all of these. So this just kind of laying the lay of the land there. All right. So a little bit on anatomy. So your central nervous system is your brain and spinal cord, and it's really what controls the rest of the nervous system in your body. The peripheral nervous system is everything else. So basically all the nerves that come off of your brain and spinal cord, that is, so the cranial nerves and then the 31 pairs that come off the spinal cord. And within those nerves, you have your sensory neurons and your motor neurons. So usually the sensory neurons, if you think about it, like sensation, like touch. So it's coming from the outside, from the periphery, and it's going to the central nervous system, the brain and spinal cord. So they are afferent or bringing information in. Okay, and then you have motor neurons, which they run from the central nervous system to the muscles in your body. So like if I touch something and I got the sensation that it was hot, that information will go to the brain. And then my brain would say, pull away, move my muscles to pull away, and it would use the motor neurons, and those were efferent neurons. So they have a different direction of impulse travel. And within the peripheral nervous system, you have the autonomic nervous system, and it controls involuntary functions. So things like heart rate and your normal rate of breathing, your default rate of breathing, digestive functions, and all of those things that you don't think about that happen in your body. There are 3 layers of membranes that surround the central nervous system, so your brain and spinal cord. And in there are the 3 meninges. So the dura mater, the arachnoid mater, and the pia mater. The pia mater is the one on top of the brain. The dura mater is the one that is by the skull. And in the subarachnoid space is where you find the spinal fluid, and the spinal fluid functions as a cushion and maintains a controlled environment for the central nervous system. There is such a thing as the blood-brain barrier, and the idea of the blood-brain barrier is it prevents certain things from entering the central nervous system, and they remain in the blood. So it's an interface between the capillaries and the brain matter, and its function of different brain cells that are involved there to kind of shield and control what gets diffused out of the capillaries and enter the brain. So it is not as it's a barrier. It's not as tight as we thought. It is possible to have what we call even a leaky brain, so damages to the blood-brain barrier, so where then you have substances that cross that aren't supposed to be crossing, often caused by inflammation. And so if you have abnormal substances that can cross the blood-brain barrier and that are present there, then usually can indicate a damage to the blood-brain barrier, and you would pick up on those substances in the spinal fluid, which we can analyze. So a little bit more on peripheral and autonomic systems. So the peripheral nervous system, you have the 12 pairs of cranial nerves that come off here, and then the 31 pairs of spinal nerves coming out of the spinal cord. And your autonomic system, as I said, controls your involuntary processes, and it can be further subdivided into sympathetic and parasympathetic. And it's, if you will, think of sympathetic as your stress and react and do stuff system, and parasympathetic as rest and digest. So and they always have opposite actions where, you know, they innervate all of your systems, that especially those that function on an autonomic system. And your sympathetic system, for example, let's say for your heart, your sympathetic system with stress then would increase your heart rate. It would make it go up. But then if you activated the parasympathetic system, it would decrease your heart rate. One way to activate the parasympathetic system to calm yourself down, if you didn't know, is to lengthen your exhale. So if you inhale to a count of 2 and exhale to a count of 4, you actually automatically activate your parasympathetic system and like calm yourself down. And you can do in several rounds of that. If you have an elevated heart rate, oftentimes you can just lower it. Since it has a rest and digest function for the parasympathetic, the digestion is triggered by parasympathetic impulses and it's stopped by sympathetic impulses. Rest is triggered by parasympathetic impulses and it's stopped by sympathetic impulses. So they always have opposite effect, but whether they start or stop a process kind of depends on what the process is. All right, neurons are really the building blocks of your nervous system. They're the little functional unit of the nervous system, and there are cells that have an axon, a body, and dendrites. And the impulse always goes from the dendrites to the body to the axon. Always travels in that direction. So the dendrites are little like tentacles, if you will, that can receive the impulse. They're attached to the body. And then usually attached to the body, sometimes they're attached to an axon, then the body goes into an axon, and an axon can be very long, and the length of the axon can be actually the length of a big part of the nerve. And then at the end of the axon, it connects to another neuron or to a receptor or something. And neurons are insulated by the myelin sheath. And the myelin sheath keeps the impulses traveling in the same directions, and it keeps them from jumping from one nerve to the next. So same reason you would insulate wires in your home, you want insulated neurons so that the signals don't jump around and get jumbled. All right, let's talk a little bit about neural tube defects. Those are birth defects, and there's a defective closure of the neural pores, which is an opening in the anterior or posterior end of the neural tube of the developing embryo. So here are 2 neural tube defects that are illustrated for you. So you see you have the body of the vertebrae. Here you have the spinal cord there. And then here's the back, you know, the skin of the back. And in this one is meningomyelocele. You have part of the spinal cord here is folded over and protruding out. And this one is just the meninges and fluid that's protruding out there. The anencephaly, which is not illustrated here, is the most severe, and the skull fails to develop properly, and there are parts of the brain that are missing. The open neural tube defects, you have hydrocephalus, so the neural tissue is exposed and the CSF, the spinal fluid, leaks out, so that's not a good one. Closed neural tube defect, which is like these right here, so there's no leaking of the spinal fluid, it is contained. You have spina bifida, and they only involve the spine, and it's an abnormal formation, so these are formed, if you will, of spina bifida right there, the meningomyelocele and the meningocele. And the quad screen is a test that is done to screen for neural tube defects, and it contains the alpha fetoprotein with ACG, the estriol, and the inhibin A. All right, cerebral palsy. This one is permanent motor dysfunction with lack of coordination, spasticity, and paralysis. Spasticity is when you have like spastic movements like that and they can't control them, and paralysis obviously is when they can't move. It is usually caused by a brain injury, and a brain injury could be because of prenatal conditions. So again, exposure to chemicals and different things, but also, any trauma to the mom, but then birth trauma and low birth weight. Those are all potential causes of cerebral palsy. And again, if you think about a low birth weight, babies that have low birth weight usually have not had adequate nutrition in utero, or were exposed to toxins and stuff like cigarette smoke and alcohol and things like that. So they're already kind of starting off with a problem. So this is the leading cause of childhood disability, and it affects function and development. The lab tests that are done are usually done to rule out other conditions and not to diagnose it itself. Sorry, this is my dog's squeaky toy, and she insists on playing with it while I'm recording a video. Hydrocephalus is the disturbance of spinal fluid flow, formation, and absorption. It leads to increased volume. The symptoms are what they call the characteristic feet stuck to the floor. So the best way to describe that, so imagine you are standing right there, just standing, and it feels like you have big old magnets on your feet that are sticking you to the floor, and you can't pick your feet up and move. And that's one of the symptoms of hydrocephalus. There's no blood test to assist in this diagnosis, and the spinal fluid studies are usually done to rule out any kind of residual infection and stuff. So there's too much spinal fluid on hydrocephalus. Hydro is water, cephalus head, brain, so it's like water on the brain, basically. If it happens, of course, when they're little, what happens is their head, this part of the head, can really expand and have a really, really big head. Okay, so hematomas and hemorrhage. All right. There are different locations for that. So epidural hematoma or epidural hemorrhage. Hematoma would be a bruise. A hemorrhage would be leaking, bleeding of a vessel. Epidural, you have bleeding between the dura mater and the bone. Subdural would be bleeding between the dura mater and the arachnoid membrane or arachnoid matter, which is so the outermost and then the next layer of the meninges. And then subarachnoid hemorrhage, it would be bleeding into the subarachnoid space. So again, I don't know if you can see all of them here, but so the bones here, dura mater's in purple right there. Arachnoid is here in the orange color, and then you have the subarachnoid space, and then this pia mater's in this peachy color right there. Give you kind of an idea. So there you go. So there's possibilities. Of course, the problem with hematoma and or hemorrhage is that there's no place for it to go, and so it creates pressure wherever it's at as the blood is accumulating or the bruise is forming and stuff, and so it can interfere with the brain function in the location where the hemorrhage or hematoma is located. Sometimes what they'll do, especially if it's like an epidural hematoma or hemorrhage, is they might drill a hole in there through the skull to relieve the pressure and let it bleed, the blood come out and relieve the pressure on the brain. Okay, so meningitis. Now this one we're definitely involved in testing for. So it's an infection of the meninges. It can be bacterial, viral, or caused by acid-fast bacteria, spirochete bacteria, parasites, or fungi. So all kinds of causes. Symptoms are fever, headache, and neck stiffness. The neck stiffness is pretty, and there's confusion and all that, but the neck stiffness there is pretty indicative of meningitis. The lab tests that are done, so we'll always do a CBC. That helps determine source of meningitis, and it can also help point in the direction of whether it's bacterial or viral, because you remember with bacterial infections, you tend to have a higher white count. And then the differential can also indicate what kind of cells are being monopolized there called to fight the infection. So again, if you see a high white count with a lot of neutrophils in the CBC, then you could suspect like a bacterial meningitis if we had the other signs and symptoms of meningitis. They will do routine chemistry and coagulation studies, just a screening test. They don't expect them to be like really out of whack or kind of weird. They will do a syphilis screening test to rule out tertiary syphilis. Now, they wouldn't do that probably on babies and stuff because they haven't had time to have tertiary syphilis and stuff like that. But on adults, and especially on older adults, they will do that. And then on the spinal fluid analysis, so they'll draw spinal fluid. They'll do a cell count, spinal fluid, protein and glucose, and a culture and gram stain. And there's some other tests we'll talk about that can be done also. Okay, encephalitis is a viral infection of the brain, and symptoms are fever, headache, neck pain. So all three of those are similar to what we just looked at for meningitis, but on top of that, you have nausea, vomiting, personality changes, etc. They are cause more of estimative like the West Nile virus. And so the lab testing, of course, we're going to do spinal fluid studies and with a cell count, protein and glucose, but then we can also do herpes simplex virus studies, West Nile studies, CMV and EBV, so cytomegalovirus and Epstein-Barr virus viral studies. Current practice is to perform PCR analysis for suspected viruses. Sorry, because viral cultures can take up to 3 weeks. Sorry. All right, CREUTZFELDT-JAKOB disease is caused by prions. So prions are infectious proteins. Their proteins are actually really good that are misfolded and really good into talking normally folded protein into misfolding, and then all the misfolded proteins precipitate and basically poke holes in your brain. That's a really simple way to explain it. It is transmissible, and it's this is the one that's relates mad cow disease, so you can get it if you have eaten uncooked like hamburger meat and stuff that's from a contaminated cow. And it is also, here's what's scary though, if they do surgery, like neurosurgery on a patient that has CREUTZFELDT-JAKOB disease and they don't know, they didn't screen, and the instruments, even if after they take them central sterile, are still contaminated and can still transmit it. And there's, if you look it up, there's a case where 18 people were, ended up with this disease because of having had surgery and the instruments were contaminated. There is no signal diagnostic test. We do spinal fluid testing on brain-specific proteins, such as protein 14-33, neuron-specific NLAs, and tau protein to aid in the diagnosis, but a brain biopsy. And really, actually, that one is confirmed at autopsy. They know for sure at autopsy that that's what's going on. All right, NATASHA'S case. All right, she's a 25-year-old woman who's experiencing blurred vision, fatigue, poor concentration, and speech issues spanning a 2-week period. It seems to be resolving, but has not gone away. During the next 3 months, she has other unusual symptoms, including fatigue, weakness in her right arm, and muscle spasms in her fingers. Her provider treats the symptoms. When muscle weakness in her leg, spasm in her foot, and general weakness occur at 6 months, her provider decides to do an in-depth workup. Her lab results are a glucose of 98, it should be milligrams per DL, not grams per DL, BUN of 20 milligrams per DL, a creatinine of 72 milligrams per DL, a sodium of 139 milliequivalents, potassium of 4.5, chloride of 106, CO2 of 26, a phosphorus of 2.5, and a calcium of 9.8. The total protein is 6.6, albumin 4.2, alkaline phosphatase 224, LDH 178, CK 42, AST16 and ALT16 international units per liter. Her total cholesterol is 188 milligrams per deciliter. Triglyceride is 167. HDL is 52. And then they do a serum protein electrophoresis that shows oligoclonal banding, which are bands in the gamma region, which is the antibody region. Okay, so in your Neopod, you have to tell me what you think she has. All right, so we're going to go over several, and I'll indicate which one she has when we get to it. All right, dementia is a chronic disorder that increases with advancing age, and the causes include neurodegenerative and vascular diseases. And where basically the patients slowly lose their mental capacities, are confused. They tend to revert back to childhood slowly. They often don't recognize their peers, or their children, or sometimes they think that their grandchildren are their children, and anyway, they can get really confused. So some of the causes with the neurodegenerative and vascular diseases are linked to diabetes and dementia, and even on Alzheimer's have been coined type 3 diabetes because there's such a strong link to those metabolic diseases. So as lab tests, we would do CBC, glucose, renal and liver function, syphilis to rule out tertiary syphilis because it also gives mental status changes in some forms of dementia. Vitamin B12 and thyroid function. If your thyroid is not working optimally, you can have problems processing and memory and all that kind of stuff. Same thing with B12. B12 affects neurologic function and all that. So you want to just kind of like run everything. This would also uncover some of the maybe diabetes and other things like that, but you want to cover all your bases and make sure it's not nutritional or hormonal based or syphilis or something like that. So and it's one of those dementia they rule out and look for all the other causes and with the signs and symptoms and imaging and everything to end up diagnosing it. So like a diagnosis of exclusion. All right, specifically Alzheimer's disease is a neurodegenerative dementia. So again, often coined type 3 diabetes. It's you get amyloid deposits and intraneuronal deposit of tau protein. And so these amyloid proteins are related to having like chronically high blood sugars. And it's like a sticky deposit, sticky proteins that precipitate in the brain and cause some degenerative changes. So you can have mild, moderate, or severe Alzheimer's depending on the loss of function and the neurological changes. And again, the lab testing, which is all the same lab testing as mentioned for dementia, because Alzheimer's is a form of dementia. It's mostly to rule out other diseases and find maybe some other underlying causes that might be contributing to it. All right, Parkinson's. So it's a degenerative neurologic disease also, but it involves the basal ganglia. Now here's a side note that's interesting. Parkinson's disease tends to affect men more, and Alzheimer's disease tends to affect women more. They don't know why. It's just, now I'm not saying that a man cannot have Alzheimer's or that a woman can't have Parkinson's. It's just statistically more men have Parkinson's and more women have Alzheimer's. So in the basal ganglia, sorry for the interruption. Okay, so in Parkinson involves the basal ganglia, and there's a lack of dopamine, which causes faulty nerve transmissions. The symptoms of Parkinson's are tremor, difficulty walking, and a shuffling gait. So this is a fun one. Look up, there's some videos where, so you can see these people, they just have trouble just walking. So they tend to drag their feet, and it's just walking this hard. But for some reason, if you play music and they move to music like dance, then they almost can like walk normally. And so this is really interesting. There's all kinds of videos on YouTube that was really interesting. The lab tests that are done for Parkinson's disease are, so there are some specialized spinal fluid studies that can be performed to aid in the diagnosis, but there's not really any like specific tests for Parkinson's disease. So again, you probably do the same battery as for dementia and try to rule out and find other causes, but with the signs and symptoms and everything, usually they arrive to the diagnosis of Parkinson's. Amyotrophic lateral sclerosis, also known as Lou Gehrig's disease or ALS. It's a degenerative disease of the motor neurons. It is incurable and has about a 3-year survival rate, as in most people, once they get it, they live about 3 years and that's it. That's average again. Initial symptoms are tripping, stumbling, and reduced dexterity. So dexterity is like your ability to grab and to do things, fine motor skills, and that kind of stuff. The advanced symptoms then are muscle atrophy. So the muscles are getting smaller from lack of use, but it's lack of use because they can't use it, right? Spasticity and contractures. So contractures are where like muscles are like tight and you can't very hard. It's very hard to pull to get it like limbs to straighten out and stuff. The lab tests that are done for ALS are again designed to rule out other diseases. There's an anti-ganglioside M1, so anti-GM1 antibody testing, and it is seen in some ALS patients, but not all. And there are genetic tests available, but you have to have appropriate genetic counseling to interpret those. So. And then multiple sclerosis, an autoimmune disease, and it predominantly affects women, especially women between the ages of 20 and 40. And it destroys myelin sheath, which gives you all kinds of neural symptoms. And so the symptoms are all of neurologic deficits, and then you will have remission. So things come and go away, and then they come back, and then you have this cycle of relapse and then remissions and relapse and remissions and stuff. So multiple sclerosis is what our patient Natasha has. And so how do we diagnose multiple sclerosis? So you have the clinical findings along with some ancillary testing. So most blood studies are normal, so the blood work really doesn't show anything. But in the spinal fluid studies, you would see that oligoclonal band pattern in IgG production and stuff in the spinal fluid. And that's pretty much the only thing you'll see there. But MRI studies are really good at helping to diagnose this. So sometimes if the MRI shows that they have multiple sclerosis, they may not do the spinal fluid studies, just because spinal fluid studies are invasive and MRI studies are not. All right, Guillain-Barré syndrome is an acute autoimmune disorder in which you have anti-myelin antibody. So resembles for that, multiple sclerosis, because the myelin sheath is destroyed in multiple sclerosis, and then this one you have anti-myelin antibody. And it's usually a response to an infection or immunization. So this one is the one that is a complication of routine immunizations, and they know. So they know that there are many complications to routine immunizations, but not that many people get them. So, it's listed on the risks. And when you get immunized, you may or may not develop Guillain-Barré syndrome. So if you're interested in what damage immunizations can do, you can look up. There's a vaccine injury registry where you can go look those up. And you'll see Guillain-Barré syndrome on that. And then you can see what types of vaccines tend to cause what type of injury. The lab tests that are performed for Guillain-Barré is, so there's not much to help with the diagnosis. So the spinal fluid studies might be helpful. Again, it's going to be a diagnosis of exclusion. Most patients will have elevated spinal fluid protein levels and normal cell counts. And you'll see a rise in the spinal fluid protein with subsequent punctures. So as in each time you get spinal fluid and send it for testing, the protein levels go up and up and up. But with the white cell count remains normal, and that would be suggestive of Guillain-Barré, because what is it that's increasing the protein is the level of autoantibodies, anti-myelin antibodies that are in that spinal fluid. It just keeps getting worse and worse and worse. So those levels go up. That means the protein goes up, but there aren't any white cells or any infection or anything like that going on. All right, so let's talk a little bit about spinal fluid collection, since that's basically the predominant lab test that is associated with the neurological diseases. So first, the puncture is done between the L3 and L4 vertebrae, so lumbar area. L is for lumbar. When the puncture is done, the spinal fluid pressure is measured, because that could be an indication. For example, if there's too much spinal fluid, there would be high pressures and stuff. Generally, 4 tubes are collected, and the tubes have etched numbers in them in the plastic. So I don't know if you can see them here, but they are numbered. And they have to be collected in order, so the physician must pay attention. Sometimes they don't, and then they have to try to write on them what tube's what. So tube number 1 is collected first, then 2, then 3, then 4. And they need to be delivered immediately to the lab, and the normal spinal fluid is clear and colorless. So yes, the nurses have to deliver it immediately to the lab. If you receive a spinal fluid into a lab, it is automatically a stat test. Like, you cannot let it sit. You have to start on the spinal fluid. It is very important to process it right away. All right, so it is important to differentiate traumatic tap from true hemorrhage. So in a traumatic tap, the amount of blood will decrease with each subsequent tube. So there will be more blood in tube 1, less in 2, less in 3, and then hopefully none at all in 3 or 4. And xanthochromia is not present. So xanthochromia is the presence of a yellow or pink color tinge to the spinal fluid. So you will not see xanthochromia with a traumatic tap. In a hemorrhage, the amount of blood remains the same in all the tubes, and the D-dimer test is often positive, and xanthochromia is often present also. So that indicates more of a longer-term bleed or hemorrhage, but so you could suspect that too. So anyway, that's one, because it is possible to get a bloody tap. How do you get a traumatic tap? Is when you tap into between the L3 and L4, you end up hitting a vein or artery or something like that, and you end up getting blood in the specimen, which is not what they're trying to do. Okay, so now here's where it gets interesting. Depending on where you look, they'll tell you different things on which tube should go first and which tube, well, what to do and what. So I'm going to give you the 2 most found, and really tell you that once you get to work in a lab, and if you're having to process spinal fluids, you just do it per your lab protocol. Okay, so microbiology testing is usually tube 1 or 3. So some people will prefer tube 3 because then you wouldn't have any skin contamination, although you're not supposed to have any skin contamination because they're supposed to decontaminate all of that, but so you could do tube 1. The routine testing for micro will include a culture and a gram stain, a cryptococcal antigen testing in patients that have cryptococcal meningitis would be, for example, your HIV and immunocompromised patients. And then usually if there's enough, you can send the rest of what's in after you've set up your culture and your gram stain, you can send the rest off to do viral cultures, AFB testing, VDRL testing, or PCR testing for a lot of those viruses. Tube 2 often goes to cytology for cytology studies, and this is different from what goes to hematology. Okay. So if there's a need for cytology studies, it's tube 2. Spinal fluid chemistry, so it would be tube 2 or 3, depending again on the protocol and the needs. The main test is protein and glucose. That one is pretty much always ordered. And again, lots of protein would be reflective of antibody productions and stuff. And then the glucose should be about 2/3 of the glucose in the blood. So the glucose in the spinal fluid is usually about 60% or 2/3 of the blood glucose. If that's the case, then that's normal. And if it's lower than that, then it is possible that you have like a bacteria in there, or maybe even a parasite, something that's using up the glucose at a higher rate. And so a lower glucose than 2/3 of what the blood glucose is could indicate a bacterial infection, bacterial meningitis of some sort. You can also do lactic acid and LDH. LDH is kind of non-specific. Lactic acid indicates anaerobic metabolism. You can do IgG, so again, might be helpful with protein electrophoresis for the multiple sclerosis and stuff. You can do CRP markers of inflammation, again, very non-specific. You can do some tumor markers if there are tumors in the brain, and of course the electrophoresis and myelin basic protein for your multiple sclerosis type of diagnosis. So the hematology testing could be tube 3 or 4. You generally do not want to do tube 1 for hematology because it might be contaminated. It might have some of the cells from the puncture, so it's usually not a good. You usually want one of the later tubes for hematology. So you do a CSF cell count, often used using a hemocytometer. Occasionally, I've seen them run through some of the machines. It just depends on their sensitivity and how low the machines can count, and if you can run spinal fluid through it. But the hemocytometer is kind of the default. And once you count your white cells and you count your red cells. Within the white cells, you need to also make a slide and stain it with a right stain and do a sorta differential. And so you're looking for monocytes, lymphocytes, neutrophils, and you report them and try to report them as percentages, but sometimes you may not even find 100 cells to count. So you have to indicate how many cells you found, how many cells you counted, and then how many were of each. And then, of course, the red count indicates bleeding and stuff. If you see malignant cells, then you need to send the tube 2 or that tube that you're working with to cytology. Okay, lastly, a note on the order of tubes. Again, the tubes used for spinal fluid aspiration are generally pre-numbered, 1 through 3 or 1 through 4, with tube 1 being the first tube filled. If possible, tube 1 should be reserved for non-routine studies because it's most likely to be contaminated with cells and stuff from the puncture. Tube 2 can be used for immunology or chemistry testing. Tube 3 can be used for microbiology testing. Hematology analysis is typically performed on the last tube collected, so 3 or 4, to assure that any peripheral blood that was in there from the puncture is gone, has cleared. Okay. If you only have 3 tubes, tube 2 is often reserved for microbiology, and then 3 for hematology. Tube 3 is often shared, so you do the hematology testing first, and then you follow it with any chemistry or immunology testing. One of the things that's not noted on here and may be pertinent to your case study this week is if you do they do a spinal fluid tap on a baby or a child, it is very possible that they cannot obtain that many tubes. It's very possible that all they'll get is 1 or maybe 2. If they get just 1 or 2, well, that's what you work with. And sometimes, especially if the volume is low, it's necessary to ask the physician what their preference is. Like, what is it that they have to have, and what is it that they wish to have that you could still do, that maybe you could do if you have enough. So it's like, what's your priority order? Because let's say if we have just 1 tube, out of that 1 tube, what is it you absolutely want? And then you have to think, for example, if they absolutely want a gram stain in culture, then you may want to go start that because it just takes a little bit, but you don't want to contaminate it as you access it for other things. And so anyway, you would set up a gram stain in culture first. Oftentimes you can do hemocytometer count with very little, so you should probably at least do that. It takes a little bit more to run the chemistry because you have to have enough for the machine to pick it up. But if you're really creative, then after the machine is picked up and run your spinal fluid chemistries, you could take what's in that little cup and put it back into a send out tube or something, and then use that to send it if you needed to send it for a panel, or use it for some of the latex agglutination panels and stuff like that. So anyway, one of the things to absolutely remember is not everybody does it the same, and just to follow your protocol in the lab where you're located, and you just use your good sense and work with the physician to accomplish the task and get the information needed for the patient. All right, and that's the end of your lecture. Thank you so much for your attention.